So, a very good evening to all of you. This academic meeting is a memorable beginning to my tenure as the president of Thane ISA. Last month, we celebrated World Anesthesia Day with great enthusiasm. We trained more than 500 people for COLS. We performed street plays, public awareness programs, and we also did head injury awareness programs at Thane railway station. We had blood donation drive and collected 51 units of blood. The program had a wide media coverage and was a huge success. As we all know, that 16th October is celebrated as World Anesthesia Day. And on this very day, way back in 1846, the first anesthetic was given, an inhalational agent, with the use of inhalational agent diethyl ether. Inhalational agents like nitrous oxide, ether, and chloroform ruled the world of anesthesia in those days. Later came the era of local anesthetics, nerve blocks, spinal and epidural anesthesia. IV induction agents were introduced in 1930s. And over the years, we've kept on getting new induction agents. And over the decades, IV as well as inhalational agents have got refined, and now we have more potent and less toxic drugs available. So, our today's topic of total intravenous anesthesia, TIVA, is the perfect topic to start with after the World Anesthesia Day celebration, a day on which inhalational anesthesia was introduced. Now, I welcome our scientific committee member, Dr. Shamini Iyer. She is a practicing anesthesiologist at Bethany Hospital, Thane, and she will introduce our first speaker. We also have Dr. Rashmi, who's joined our one of the uh, other speakers, Dr. Rashmi Shingade, ma'am. Welcome, ma'am.
Yeah.
Yeah. Shamini, over to you.
Thank you, Parna. Good evening, everyone. Without wasting much time, let's get started. It gives me immense pleasure to introduce our first speaker of this evening, Dr. Kalpana Shah. She's a panel consultant in cardiac anesthesia at Breach Candy Hospital and Jaslok's Hospital, Mumbai. Her areas of interest include prehabilitation, TIVA, TCI, and teaching. Today, she would be enlightening us about understanding TIVA, TCI. Kalpana Shah, over to you, please.
Thank you, Shamini, for that lovely introduction. And it's nice to see you. Nice to see my classmate Shamini and Meenal Prabhugat is also there. Thank you so much. May I share my slides, please?
Yes, yes.
Can you see my slides now?
Yes.
Okay. Good evening, respected colleagues and dear friends. And I'm indeed overwhelmed to be present here and extend my gratitude to the organizing committee and to Dr. Parna Thakkar for this opportunity. My topic being understanding total intravenous anesthesia and target control infusion. As an anesthesiologist, the knowledge that one requires when you are embarking on your journey of TIVA to CI is to know the appropriate plasma and the brain concentration for the IV anesthetic drug that you are using. Also, the appropriate target drug concentration, that is the effect site concentration, the practical aspects of setting up a TCI pump, and the use and interpretation of processed EEG. So through my talk, my objective is going to be to take you through the PKPD of propofol, also to understand the different models of propofol available in the TCI pump, to understand the basics of three-compartment model, and also how to operate a target control infusion pump. This black little bottle that you see right in the left-hand corner is nothing but 2,6-diisopropofenol. This was a very potent sedative and a hypnotic. Now, if you were to take this bottle and dump it into a beaker of water, it would show a nice layer of like a vegetable oil. So it was completely immiscible. So the problem arose that how are we going to deliver this to human beings? We need to thank Dr. Ian Glenn for his indomitable spirit, though being a veterinary medicine person, and he worked putting in many lipid emulsions and formulations, and he has paved the way for the Milky Way, and that's how we all are using propofol in our daily practice. Now, when you consider pharmacokinetic and dynamic, which are the crucial concepts in pharmacology, pharmacokinetic studies give us the information on how the drugs are absorbed, distributed, metabolized, and excreted by the body. And this is used to, give us different dosing regimens and predict the drug behavior in patients. The pharmacodynamic will give us an information on how this drug is going to interact with the body to produce a therapeutic effect. And hence, we can optimize the drug efficacy and minimize the side effects. So, hence, a PKPD is very important for us to understand. And keeping that in mind, propofol, as you all know, is a drug which is very short acting, a very fast onset intravenous anesthetic agent. Of course, it requires a very acute titration for induction and maintenance of anesthesia because it has got a very, very narrow therapeutic index. So you need to carefully administer it. Underdosing can have patient movement and awakening and possibly recall. Overdosing can cause hypotension and respiratory depression. Mind you, friends, propofol is not an analgesic. So you need to use some adjuvants like opioids, regional or multimodal analgesia when you're giving it for an anesthetic purpose. Having said this, total intravenous anesthesia is a technique of general anesthesia where you are using combination of agents which are given solely by intravenous route in absence of inhalational agents, and this includes nitrous oxide as well. So then the thing came that when we had total intravenous anesthesia, then why do we need a TCR? So when we would give, say, propofol for a patient for a surgery, we would give a bolus, and then we would, as the surgery would go on, we would keep on giving these boluses to the patient. Now, this would not achieve a therapeutic range. You would get many peaks and troughs, and this will again bring about its pharmacodynamic hit. So then people said, okay, let us start giving it as a continuous infusion. If you were giving it as a continuous infusion, you would take quite some time to reach the therapeutic range. So again, in between that time, you can have possible awareness or a recall. At the same time, if you're giving the same dose continuously, then the patient's recovery profile would be very different. It would take a long time for the patient to come out. So what we needed was something like the MAC, which in which like a vaporizer in a MAC, where the target is achieved without any of this fuss. So what did Price and Roberts do in 1988? They studied multiple blood-brain concentration, and they found out that for general anesthesia, you require about around 1.5 to 6 microgram. And the target control was much better with 3 microgram per ml of propofol. So they discovered a dosing regimen where they gave a loading dose of 1 milligram per kg, followed by 10 milligram per kg for 10 minutes, 8 milligram for next 10 minutes, and then 6 milligram thereafter. Now, recovery after, say, a 90-minute procedure would take around 10 to 15 minutes. We were not happy with this because the recovery profile again was very, very erratic. Hence came in TCI, which is nothing but a computer control system which precisely regulates the drug delivery and maintains the desired depth of anesthesia. And how does it do that? It accurately models the drug's pharmacokinetics by calculating the infusion rate to achieve the specific brain concentration. So, what I need to urge all the anesthesiologists here, we have to move away from milligram per kg dosing to target concentration. That is what PCR has brought about. So, if you were to use a target control infusion and you were given a target of a particular drug, which you would have fed in, then the pump would work with the help of its pharmacokinetic principles and stimulation that it has, and will give you a varying infusion rate. You are not to calculate. It calculates the rate according to the patient's height and weight. The infusion has been given to the patient. You, on the other hand, knowing and observing the patient's hemodynamics, his BIS values, the target plasma concentration or effect site concentration, can then go and designate this target concentration. You can bring it down or you can hike it up according to the level of the surgical stimulus you are in. So PCI is a computer control system. It regulates your drug delivery, gives you the desired depth, and you do not have to calculate the target concentrations. It is calculated by the pharmacokinetic model that you have put in. So since we had many models which were very accurate, that was one of the key reasons to shift from TIVA to TCI. It was a controlled drug delivery that we had. We were able to adjust the the dosage regimen or the target according to the surgical stimulus. We had consistent, reproducible results, a faster wake up profile. The patient would just get up as if he just had a nap. And these techniques are really standardized, and you can obviously teach them and go ahead with doing more research in the same. So, if you were to understand how this magic of TCI works, there are three main components that you need to understand. One is the three compartment model, the next is effect sites and plasma sites, and the context sensitive half time. So the relationship between the plasma site and the effect site concentration is best explained by a three compartment model. Now, if you were to give a bolus of, say, propofol to a patient, what will happen is you will get a very high plasma concentration, which is represented here in this graphic presentation as initial volume of distribution or V1. Now, this is then going to get distributed into two smaller compartments, V2 and V3. V2 is a muscle compartment, which is, of course, vessel rich. And because it is vessel rich, it is rapidly equilibrating. The next is V3, which is a larger compartment, which is fat. It is vessel poor, and hence it is slowly equilibrating compartment. Now, friends, we all know propofol is a lipid soluble. So hence it has got a very high volume of distribution in V3. Now, the volume of distribution in a steady state is the sum of V1, V2, and V3. And this proportion of the drug, which is moving to and fro from each of these compartments, is represented by a rate constant called as K. The rate constant is also shown between the plasma and the effect site, and this is called as KEO. This holds a lot of importance in our further discussions. Now, the size of each of this compartment and the intercompartmental clearances will, of course, depend upon the property of the drug that you are using, the tissue binding. So, hence, the model of propofol, this model, when you are using it, say, for the drug of propofol, is not going to be the same for some other drug. So, we need to know the distribution, redistribution, metabolism, and clearances of each of this drug in understanding with the three compartment model. The next is context sensitive half time. So this is the time for the plasma concentration, or you can say the effect site concentration, to decrease by 50% after you have stopped your infusion. So if I would have run a propofol infusion for 2 hour surgery, it would take around 30 to 40 minutes for the propofol effect to wear out. But remember, propofol is biphasic, with its initial half-life being 40 minutes. The terminal half-life is going to be around 4 to 7 hours. Now, if you're going to run a propofol infusion, say, in the ICU for a longer period of time, then the context sensitive half time or the propofol can remain in the circulation for a real longer period of time. In the same patient, if I were to run a fentanyl infusion for 2 hours, then after stopping the infusion, it would take around more than 60 minutes for the fentanyl effect to go away. And the new kid on the block is remifentanil. Now, remifentanil has got a very short context sensitive half time, which is around less than 5 minutes. And this is because gets rapidly metabolized by cholinesterase, which is found in our blood. So hence, it's like a quick in and a quick out, short acting opioid, which is the new kid on the block. The next concept that we need to understand is the plasma targeting and the effect site targeting. So if I'm going to target the plasma when I'm using a TCI, so this red line that you're seeing is I have targeted the plasma, say, at 3 microgram per ml for propofol. What will happen is for it to achieve a steady state, that is the effect size, that the brain concentration should also have the same amount of effect of the drug. It's going to take some time because when you target the plasma, the steady state is going to have a slow onset and a slow offset because the plasma concentration is never going to overshoot. So if you can see the gray zone, till the effect size and the steady state plasma concentration is going to come in a steady state, this is going to be a gray area where your patient is going to be aware. So when you're doing plasma targeting, it's going to be really slow onset. Vis-a-vis when you do an effect site targeting, what happens is, say you have put your effect site targeting at 3. The plasma is going to shoot to 6 or 9 micrograms so that it can quickly reach the effect site. So it's a quick onset and a quick offset. But remember, this does come with the pharmacodynamic effects of the drug that you're going to use. A brief word about KEO, which I mentioned, is a rate constant, which describes the time lag between plasma concentration and effect site concentration. So if you have a larger KEO, then the time lag is going to be very short. So friends, TCI is just like driving a Tesla car. Really simple. You just set your target. You can titrate it up and down according to the surgical stimulus that you have. And then you can just sit back and relax. So a typical TCI system consists of 3 main components. You first have a user interface with a display and a data input method. It does have a microprocessor which runs the pharmacokinetic modeling software which you have fed in, which the company feeds and gives you, and there are multiple softwares for different drugs available. And then you have the infusion device, which has got this visual and audible safety alarms that you use. And mind you, these infusion devices should be able to deliver high infusion rate up to 1200 ml per hour with a precision of even as less as 0.1 ml per hour. So this is a 40-year-old mature technology which is evolving. We have many pumps which have come into the market, and there have been many vendors who are there. At the same time, Charles Minto, Thomas Schneider, Michael Stoos has worked tirelessly to get us different algorithms for different models that are now available. I'd like to just enumerate the models which are available. For propofol, we've got the Schneider, we have got the Marsh model, the Eleveld, the Cottoness in adults, and we have for pediatrics the Petfuser and the Kataria model. We also have remifentanil, which has got Minto and the Eleveld model. We have for fentanyl Bergman, and for dexmedetomidine, we've got the Dyke and the newly launched Hannibal Collin model. So we need to understand what distinguishes these propofol models, that is the Marsh, Schneider, Eleveld, and the Kataria Petfuser from each other, and I'll just briefly run you through the same. So Marsh model was one of the initial models, and did use the HEP3 compartment model. And remember here, it only had one covariate, that is only the body weight. So when you put in a Marsh model, you are just putting in the body weight. That is a central compartment. B1 is going to be a compartment which is expressed in ml per kg, tells you about the body weight. All the other transfer rates are very fixed. So if I were to extrapolate the same thing in the 3 compartment model which I just showed you, the V1, which is a central volume of distribution, here it is going to be 228 ml per kilo. So if you have a patient who is 50 kilos or 150 kilos, it is going to multiply it by 228, and that is the bolus that the pump is going to give. Because it is not going to take into consideration the V2, the muscle mass, or the fat mass. So this is a big drawback in this model, because this will work very well if your patient is not very old, not obese. But otherwise, it is going to give you a very large induction dose, and that will cause a huge pharmacodynamic hit. And hence, it's rightly said that Marsh is harsh on induction. It's a plasma site model which is being used. The next is the Schneider model. Now, this model was brought about by Thomas Schneider and Charles Minto, again based on volunteer studies. They used the arterial samples of all these volunteers. But here they went ahead and they even fed in the height, the weight, the age, and the gender of the patient. And mind you, they also did calculate the James equation based on the lean body mass. So here what was happening is They kept the central compartment and the fat compartment, that is V1 and V3 fixed. V2, which is the muscle compartment, which you all know is influenced by age, because as you age, your muscle mass goes down, and geriatric patient would have some amount of sarcopenia. So this was a thing which was very helpful for elderly patients, and of course not too obese patients. So if I were to extrapolate in the three compartment model, here you have 4.27, that is the fixed rate it gives. So it was a very smoother induction because a very small dose of induction is being given. The V3 was fixed, as I just mentioned to you, the covariate, but V2 was variable. So it did take into account if your patient is, elderly, and the muscle mass was very less. So this was the positive point in this model. And so you could induce a patient very smoothly if your patient was kind of a non-obese, and even an adult patient, you could, an elderly patient also, very, you could induce them with, a lot of um, being very, very comfortable inducing these patients. But what was the problem here was, um, because it used the James equation, they found out that the lean body mass after certain weight, you know, it started becoming negative. Now, because it started becoming negative, the lean body mass, your induction dose went up, right? So what this came up with kind of a limitation. So you could use Schneider, but you had a cutoff of the BMI. For a female, 35 was the BMI, and for the male, it was 42. So this was one of the drawbacks of Schneider model. You could not use it beyond these BMIs, and hence new models had to be developed. Now, when we come to a pediatric population, you know that the neonates and infants, they have a very immature hepatic and renal system, which affects the metabolism and clearance of propofol. Additionally, these people are very sensitive to the cardiovascular effects of propofol because they bring about hypotension because it has got a very small blood volume. So you require a real close monitoring for hemodynamic parameters and to maintain stability. So we did have limitations when we, tried to use the TCI models for pediatric group of patients. However, we could have gone ahead, and we did go ahead and use them with a normal infusion pump using the two regimens. One is the Stewart regimen for patients, for kids who are less than 3 years, and you could use the McFarlane regimen for patients between 3 to 11 years of age. And this was giving us a steady state plasma concentration or the effect site concentration of 3 microgram per ml. But however, they go ahead and brought in two models which were used in the TCI. So we had the peak fuser model and the Kataria model. Mind you, both these models are weight based and they are plasma based models. Now, interestingly, in children, there is no KEO because you really do not know the effect site concentration of these patients. So they are all plasma site models that we have. Petfuser can be used between 1 to 16 years of age, Kataria from 3 to 16 years of age. And remember one thing, they do have a longer context sensitive half time. So if I were to just quickly recap, we have the Marsh and the Schneider model till now, where in Marsh model, the parameter was just the weight, but in the Schneider model, we had age, height, gender, and the lean body mass was used, but we had a BMI cutoff. Whereas we had the Kataria and the Petfuser, again, weight-based models, plasma site targeting for pediatric group of patients. Now, what happens if I have two patients, both having weight of 52, but one having a very good muscle mass and less of fat, and the other one having a more of fat? Which model do I use? So there were many limitations of the models that were in the market till now. So we went through the Marsh model, which was plasma controlled, which you could use it in non-obese and non-elderly patients. Marsh does not have any effect site control monitoring at all. Schneider model, you could use it in adult, non-obese, and in elderly patients, of course, with the cutoff. They brought in a Cottonese model that was used for obese patients, and Pit Fuser again for pediatric group of patients. But we did not have any data for neonates, small children, young adolescents. Like tomorrow, if I have a case of 16-year-old teenager requiring anesthesia, I'll be sitting wondering behind the pump, should I feed in the Petuser model or should I do the Schneider model? So bringing all this thing into collating it together, Egan and Campbell brought about a study and said we really required one model which will, rule us all, and hence the for the new model, all the developers got together. So we had Douglas Ellivel, Michael Spruce, and Laura Hannibot. All of them got together, and of course they went back to studying all the models that we had, got back all the studies that we had, got back to the mathematics. I'm not going to get you into the detail of this. How did they get it? But they brought in many, many criteria: prematurity, whether opiates are used or not in the LEVEL model. They also use something called as allometric scaling. They use free fat mass in these patients. So all these criteria were taken into consideration, and they brought in one model which was brought in from data of different studies of more than 1,000 patients. And now you could induce a patient of 680 grams to 160 kilos, a premature of 27 weeks to somebody who's 88 years old, elderly patient, with height, postmenstrual age, gender, and even concomitant drugs could be used in this model, which is the LAVEL model. So what did they do? They made this pharmacodynamic calibration with the help of BIS. The studies were all considered with BIS. And you could now look at this calibration. And if you have a 40-year-old gentleman for sedation, then you know your effect site concentration, as you can see here, can be around 1, 1.2. And if you were to give anesthesia, then 3 to 3.5. Of course, this data is for the Western patients. Not, I don't, from my experience, it doesn't hold true for our Indian subset of patients. So what I did is one patient, I'm just showing you how the two different models were working. I had a 50-year-old patient looking at the same. I put in 2.7 as the effect site concentration. I fed in that data for a Schneider model, which is on top, and then below one is the LEVEL model in my PCI pump. And I found that my induction dose in the Schneider was 0.73 milligram per kilo, whereas my maintenance was around 67. The same thing, when I put in the same thing in the patient for an LEVEL model, you see my induction dose was really high, around 1.42 milligram per kg. But my maintenance dose was very low, 53.8. So LEVEL will, of course, give you a little larger bolus, but it gives you a lower infusion rate. So there is no overshoot or overpressure, and you get a consistent, steady state of narcosis in your patient. So, friends, we now have this showstopper LEVEL model, well known as one model ruling them all in all subset of special populations that you have. And what the best part about this is it is improving the patient safety. It simplifies the decision making, which model do I use? Because you have a wide variation of patients which you can anesthetize with this. It promotes the confidence, improves patient safety, and even if you're using a concomitant drug, it'll adjust the dosages to the opioid that you're using. After having told you all this, I'm sure you're going to ask me this question. Now, which model do I use? Well, if you do not have an LEVEL model, whatever existing model you have, please be familiar with the model that you're having. Always start from a low concentration and then move to a higher target concentration. Please look into the elderly, sick, and obese patient for risk of overdosage. Reduce the initial dose in compromised patients. And our mantra is just going to be titrate, titrate, titrate. At the same time, TCI depends upon the three C's: the characteristics of the patient, the co-administered drug, and the clinical situation in which you are using this. So the caveat for an induction would be, putting your target as 0.5 to 1 microgram, keep stepping it up, keep observing your effect site concentration, whether you have achieved it or not. Are you going to do AVM manipulation? Please look into your effect size again. Look at the characteristics of your patient. Look at the hemodynamics of the patient, and then go up. If you want a quicker induction, it's always better to do effect site targeting rather than plasma site targeting because it will give you a quicker induction. Also, make sure that there is no dead space between your propofol infusion line and the IV access that you have got. Okay, please use anti-reflux valve, right? And begin propofol as early as possible, right? Now, if you want to even give a bolus, to the initial, when you're setting up your infusion, you can put in the desired bolus. And if it has calculated a bolus and you feel, I don't want to give such a high dose, you have the liberty of bringing it down. It is not necessary that, what it gives, it gives. You at the other end can bring the bolus down according to the three C's that I told you. Now you can maintain your patients on the propofol infusion, and you can stop the drug when, as and when, according to the clinical situation you are in. We do recommend running a short-acting opioid, say remifentanil or maybe fentanyl along with it, and you can also titrate that up and down according to the surgical stimulus. Now, if you're using, how do you stop this thing? So, when your surgery is over, then always titrate down the drug with the slowest kinetic first. So that will depend on the drug that you're using. Supposing you're using a combination of propofol and remifentanil, then propofol is slower than remifentanil. And if you're using fentanyl and propofol, then fentanyl is slower than propofol. If some adjuvants are used, say like dexmedetomidine or ketamine, please stop it before the procedure, discontinue them. At the end of it, we do not put the pump, switch off the pump. We put it to zero so that when the patient wakes up, you know that at what level the patient went in, what effects that concentration patient went under, he was not responding to your oral commands. It's at the same CET, he's going to target concentration effect site, he's going to wake up. So you will be able to see what is the calculate your effect site concentration. It tells you how much of drug you have given and at what time the patient is regaining your consciousness. I have brought in a small video here, which I have used TIVA TCI for induction for a patient with coronary artery bypass grafting, and I have been using a Procel LMA also in some of these cases, of course, indicated ones. And here is a video to tell you show you how remifentanil and propofol I have used. So I began with using remifentanil. I started a very small dose. You can see the BIS has been applied. The BIS is around 84, and then I put in all the lines. Of course, midazolam has been given. The remifentanil has been hiked up to around 2. By now, patient is fine. Propofol has been introduced. He's kind of under. I'm ventilating him. Once this is done, I'm ventilating him with just oxygen and air, and no nitrous oxide or inhalational agents are being given to the patient. I'm titrating the propofol according to the hemodynamics of the patient. And when I put in the Procel LMA, I use the railroad technique where I pass in a gum elastic bougie, and over that, along with the introducer, I pass in the Procel LMA. And once I have placed it, remember this is a bypass surgery, so I need to be very sure of the positioning of my Procel LMA. So I need to look at the expired tidal volumes, mid ventilation, and of course, auscultating the chest. And once that is done, the tube is then fixed, the LMA is then fixed. And then through the DLT end, I put in some jelly, and I give, and if of course there is no leakage, there's no bubbling will happen, and I give a small push. This called as a block test, and my final confirmation happens with the rice tube that I put in. And here we've done the case completely with this monitoring and using remifentanil and propofol. So this is without any inhalational agent or nitrous oxide. So this is how I have conducted my case with Remi and propofol. So the next question is, I thought I would just talk about a bit about how will you prepare your remifentanil. So that's available as a 1 milligram and a 2 milligram powder that you can dissolve it in saline and make it to 50 microgram per ml. So if you have 1 milligram, you make it in 20, or 2 milligram in a 40 ml. Please use this as an intravenous infusion only. You can use it as a TCI pump, and if you do not have a TCI pump, you can use it in a normal infusion pump. Please do not put it in a drip and use it. Always use anti-reflux valve and see that your IV is always visible when you're doing that. Now, as I just said, some of them will say, I do not have a TCI pump. Well, you can yet use a remifentanil, and you can use it this way, weight in kg into 0.12. That will give you the dose in ml per hour. So for a 70 kilo patient, maybe you can use 8.4 ml. That is going to be at 0.1 microgram per kg. You can titrate it up to 0.3 microgram per kg. Mind you, with remifentanil, always see to it that you are oxygenating the patient. Muscle rigidity is very common. Bradycardia is also very common. Now, once you're terminating the remifentanil infusion, you'll have to stop, disconnect the infusion. Either you aspirate or flush the line if you're sending the patient to the wards or to the ICU, because apnea is known and bradycardia is also known. And you need to give some long-acting analgesic 10 minutes before stopping the remifentanil. At the same, so you can use either another long-acting opioids. You can use some multimodal analgesia, simple analgesics, or you can also do regional blocks and local infiltration. Remember one thing: TCI pump is a machine. You are the brain behind it. And as the LAP5 protocol did guide us that you should have some depth of anesthesia monitoring to guide your TIVA TCI, we have many depth of anesthesia monitors available. You can use the one in which you are comfortable. This entropy, narcotrend, patient state index, and cerebral state monitor. Generally, in the base beast, what we see is a processed EEG. In the unprocessed waveform that you're seeing here, if you devise the two waveforms that are there, you have a green color slow delta wave 0.1 to 1 hertz, on which the blue color, the alpha waves are piggybacking. And the red one is the suppression ratio, which should always be 0. That means because the more the suppression ratio, the more neurocognitive decline the patient may have. So this is how you read your process EEG, and then you have put in your BIS. This is all that you will see on your monitor. You will see the SQI, you will see the EMG, you will see the TEF, and the EMG, of course. So you have these 4 electrodes over here, where the first one is the reference electrode, the second one is the grounding electrode, and the fourth one is the ocular one, which records the EMG artifacts because of the eye movement. And the third one is the temporal, which is a very active electrode for recording the EEG. Now, here is again a short video telling you how to apply the BIS. So you clean your patient's forehead with a alcoholic swab, dry it, and this is the BIS which is available. It has got a conducive gel and plastic sponges. See that you firmly apply it with a pressure, all of them. The application should be really good, otherwise sometimes it may not catch any of the signals. Once it is attached, you connect it to the monitor, and you can then maybe put some adhesive taping on that so that the contact doesn't go away. And then you go onto your monitor and check for your sensors, and once they show, all three of them show green light, it means your sensor is working and you're ready to go. Of course, with BIS, you can do many things. Like if you can see this thing, if you find that your patient has got increased sympathetic response and the BIS is more than 60, you generally want to keep it between 40 and 60, then you have to increase your hypnotic. Vis-a-vis, you find that the patient has got a BIS less than 40 and your sympathetic response has also gone down, then you have to rule out cerebral hypoperfusion or consider IV fluids on vasopressors or decrease the hypnotic and analgesic. So this helps you not only for monitoring your BIS and this thing, but also for the vitals. So having said that, TIVA TCI has got many red carpet benefits. It gives you a better hemodynamic stability, reduce adverse effects, mainly postoperative nausea, vomiting, early recovery from anesthesia. You are not there to calculate all the drugs and all, because everything is done real time by your TCI pump, and allows you to give anesthesia with exceptional precision. Of course, one of the major thing is no volatile gas which is polluting the OR or the environment. So as we are moving ahead to a greener earth and we want to leave behind for our next generation a greener earth, the fight yet continues to understand who the winner is. Is it going to be the inhalational agent, or is it going to be the total intravenous anesthesia and TCI? Until we find the winner, we applaud our winners who had just won the World Cup. And I thank you all for having me here today evening. Thank you once again.
Thank you, Dr. Kalpana, for this excellent talk. It was very simple and beautifully explained. And I hope someday we can also use it here in Bethany. Next, I welcome Dr. Bhavish Nanda, who is an ISA Thane executive member. He's a director and chief anesthesiologist at Padma Shri Maternity and Nursing Home Thane, as well as the chief bariatric anesthesiologist at Asta Center, Mumbai. Over to you, Dr. Bhavish.
Good evening, everybody. After an
And we'll
excellent
take the
presentation by
questions.
Dr.
Sorry, Bhavish, just a minute.
Yeah.
We will, sorry to interrupt. We'll take the questions during the discussion. All
Correct.
questions to be addressed will be taken then.
Yeah.
Thank you.
Thank you very much, madam. we will move on to the next chapter of our today's webinar, that is use of total intravenous anesthesia in neuroanesthesia. And it will be presented by Dr. Joseph Montero. He is a chief neuro anesthesia consultant at PD Hinduja Hospital. He is a director of a DNB program, and his main area of interest is neurocritical anesthesia, neuroanesthesia, and teaching programs. So, Dr. Joseph, we will continue your talk.
Thank you very much. Can you see my slides?
Yes,
Yeah,
sir.
we can see your slide.
At the outset, let me thank ISC Thane for inviting me for this. It is wonderful to see the enthusiasm, and I can see about 92 people have logged in for this webinar. So I also thank my previous speakers. Thank you, Bhavish, for the nice, kind introduction. So my topic for today is TCI TIVA in neuroanesthesia. So TCI and TIVA is not something new, and the use of TIVA has been going on for many, many years. In fact, if you see our Indian private practitioners, they have been using TIVA a lot, much more uh, in advance, comparing to the fact that it has been now highlighted by the availability of these syringe pumps. Even before the availability of syringe pumps, TIVA was being used in India too. So my first experience in TIVA was when I went to Cambridge in 1998. Way back, that's quite a long time ago. And this is one of the studies that we had done there. Propofol anesthesia for craniotomy, a double-blind study, comparison of remifentanil, alfentanil, and fentanyl. And I was fortunate to be a part of the study. And there we summarized that there was no significant difference between the groups in the dose of propofol maintenance, heart rate or mean arterial pressure, and the time to eye opening was significantly shorter in the remifentanil group. So this happened way back in 1998. It took so many years for remifentanil to come to India. And it's very interesting to see that the European group prefers to use TIVA, especially in neuroanesthesia, as compared to the North American group. The North American group were led by uh, a small study done in patients with normal ICP, where they compared the use of inhalational versus TIVA, and they found they are equally potent. So unfortunately, hence the non-availability of syringe pumps, non-availability of these drugs caused people to continue to use inhalation agents. However, I use TIVA for most of my neuroanesthesia cases. Thanks to Dr. Kalpana, she just shared some insights into the use of remifentanil and TCI TIVA. So I will just focus on some basics first. Remifentanil is a phenylpiperidine derivative. The ester linkage provides a very unique and a favorable pharmacological profile. It is this ester linkage that undergoes metabolism by the plasma esterases, and that gives it its ultra-short action. So it is available in India in this form. It's a white amorphous powder, forms a clear solution of reconstitution. The pH is 4.5, pK is 7.07. It's a pure mu receptor agonist, and it contains glycine as a preservative, which is neurotoxic. It's very important to know this, so don't feel tempted to use remifentanil for an epidural or in your spinal, because please note that this glycine is neurotoxic. We normally always add some of us add fentanyl as an adjunct in our spinal or in the epidural. So just a word of caution. And the other disadvantage of remifentanil is ultra short acting, so it doesn't make sense adding it to prolong the action of your spinal or epidural. So as she also mentioned, there's a linear dose dependent pharmacokinetic profile, and the effect site concentration depends upon the current dose, and the half-life remains constant regardless of the concentration. 70% is bound to plasma proteins, and it readily crosses the placental barrier, but is rapidly metabolized in the neonate. It also readily crosses the blood-brain barrier. So we can see here in this diagram, linear kinetics and the non-linear kinetics. What are the doses? So in this chart, you can see very nicely the TIVA doses and the TCI doses for anesthesia depth. This is in microgram per kg per minute, and this is nanogram per ml. So for sedation and awakening, these are the values you have to focus on. 0.5 to not 0.5 for sedation awakening, and you can gradually go up. Very important to know in TCI and in TIVA, always start low and go slow. That's a very good mnemonic for you all to stay, especially when you're using the drug for the first time. Don't go by what the machine tells you. So when you're trying out, always start low, as I mentioned, and go slow. See, I mentioned here the boluses also of 0.05 to 1 microgram per kg. I don't use boluses because the problems of remifentanil, that is the bradycardia and the skeletal muscles rigidity and difficulty in ventilation, they all come up with bolus uses. I always use an infusion of about zero point 0.1 to 0.5 microgram per kg per minute. And the target effect site concentration for surgical anesthesia is 4 to 6 nanogram per ml. So now anesthesia is not a constant thing. It has to be titrated as we go. I always say that all anesthetists must know all the surgical steps. So only when you know the surgical steps will you be able to titrate your anesthesia along the landscape of the anesthesia that you give. So there are some critical parts where the stimulation is more. There are some parts where the stimulation less, where you may have to titrate your doses lower. So in neuroanesthesia, there are some very critical phases. One is the intubation, then is the pinning, infiltration of the scalp, raising the bone flap. All these are very painful parts. So in those stages, you may have to go up with your dose and titrate it. But once the dura is open, the painful part of that part of the surgery is over. So then you may have to come down to a little lower dose for the maintenance phase. This also holds good if you're giving normal anesthesia. It's not only for TIVA anesthesia. So always not only monitor the patient, I also monitor my surgeons and I keep a watch on what they are doing because then only you'll know how to titrate your dose. So it's not a thing that you fix it and let the machine take over. Even if the machine is on, one must be there monitoring your anesthetic depth, and you may be always fine tuning it. We see all these automatic driven cars which are catching the fancy of everybody with AI. But I feel you must synergize technology with the human brain. And otherwise, we will become as incompetent as we have become using Google Maps. Many people cannot even drive a normal car just because they're used to Google Maps. And in small places, like even in Thane, I'm sure if you go down some small unknown gully, you will not, the Google Maps will take you to a wrong place. So please don't give up your own intelligence in imbibing artificial intelligence. So here, this is context-sensitive half-life. The context-sensitive half-life of remifentanil is just 3 to 6 minutes. You can see here at the bottom of the screen, this is the line of remifentanil. So as much as you may infuse it, it remains low, the plasma value. And here you can see fentanyl, it just shoots up because it does not have the linear kinetics. Once again, I'll reiterate, only infusions, no boluses. It is a very potent opioid, and apnea and bradycardia are the most common side effects, and these are amplified on bolus administrations. TCI, Dr. Kalpana has spoken a lot, so I will not much go on, but it is an AI-based technology that reverse engineers the pharmacokinetics and adjusts the infusion rate to achieve and maintain the target drug concentrations. In remifentanil, we use the Minto or the Elevate model. It depends upon what model you have in your institution. So it doesn't depend on whether you own a Mercedes or you have a BMW or you're driving a Maruti. So you should be able to drive that car safely to reach from point A to point B. So it's not the drug that you have or the machines that you have, it is how you utilize it safely for the benefit of the patient. So what do you set on the interface? The name and concentration of the drug, patient details, age, weight, gender, and height. The more values that the algorithm takes in, the better is the output from the machine. There are various models, as Dr. Kalpana has said, but remember, these models are based on patients, not Indian, Caucasians, foreigners. So each one has got different pharmacokinetics and pharmacodynamics, and they are not done on Indian patients. So we have to find our own values in our Indian or South Asian subset of patients. So don't follow exactly the foreign doses when you're applying it to your patients. So this is how you prepare it. So always remember, use a lower lock syringe. So in case there's a disconnection, the drug will go into the patient and it will not spill out onto the floor, because many of these pumps may not have an alarm to tell you that there is a disconnection of the connector. So the concentration is prepared in a dose of 50 mics per ml. That is, if you have got 1 milligram in 20 ml of normal saline, if you have got 2 milligram ampule, you make it in 40 ml of normal saline. And this is a mathematical calculation to derive a simple formula. So if you have got, you don't have to be Aryabhatta or some genius in mathematics to do this simple calculation. Weight in kg into 0.12 ml per hour is equal to 0.1 microgram per kg per minute. So if you double this, it will become 0.2. If you half it, it will become 0.05. I draw my drugs myself, because suppose somebody draws up your drug but takes 1 milligram and dilutes it to 50 or to 40 ml, you will be none the wiser. So you will be using all those models, but you will have a problem because it will be not having the desired effect. Forget about the plasma effect or forget about the end site concentration. I draw my drugs up myself so that I know, and only when you have drawn up the drug do I put the label. These are small practical tips, because if you label the drug and you forget to draw up the remifentanil, you may start using it. Understood? So these are small little things you have to be careful of. Again, I'm mentioning lower lock syringes. Draw up your drug yourself. Label it only after drawing it up. So its uses of remifentanil is a very potent analgesic, and it can even facilitate intubation without muscle relaxant use. Very often, I feel as anesthetists, we tend to use too much of muscle relaxation, and I use a TOF monitor in all my cases. So it's very important to see that you don't require all the 4 twitches to be absent for your surgery. Very often, especially if you're using at least a subset of patients for neuro monitoring, you can have 0 twitches also and still you can give a good anesthesia, or you can keep 2 twitches and still you will have good SSCP and NEP monitoring. Now, if you give too deep a plane of anesthesia, it's not good. And now, with the use of Sugammadex, it is also important to use TOF, because the Sugammadex dose will be dependent upon the TOF value that you have. It also, you can prevent intubation-related hemodynamic alterations. Dr. Kalpana has demonstrated the use of that supraglottic device for a CABG surgery. So you can imagine. So every patient doesn't have to be intubated, and every patient does not need a muscle relaxation to be intubated. Remifentanil is a very potent drug. So I'll just switch over gears to my own experiences. But I'll start off with this quote: better is possible. It does not take genius. It takes diligence. It takes moral clarity. It takes ingenuity. And above all, it takes a willingness to try. This is by the famous author Atul Gawande. So it's very important now that all of you all have logged in to this the TIVA seminar on a weekday. All of us are trying to get better in what we do. So it's important that we try to get better, sharpen our skills, and get better in the anesthesia that we are giving. And that what it takes finally is a willingness to try. So here is the use of, let's just see, is it? I started off using it in a craniotomy. This is demonstrating the plasma concentration. Okay, and you can see the hemodynamics here. It's the steady state, the heart rate, the blood pressure, and I also use PPV when I'm using the arterial line. That tells me about goal-directed fluid therapy. I can titrate the amount of fluids that I give, or the choice of vasopressor if required. See, very often when you're using propofol, sometimes the doses of propofol that you may require, or the doses of remifentanil that you may require, may cause hemodynamic instability. Now, remember one thing, at least in neuroanesthesia, my aim is to maintain a good cerebral perfusion pressure, which is equal to the mean arterial pressure. which should be ideally above 60 or 70, depending upon the patient. So now it doesn't make sense to give a drug to achieve that plasma site concentration or the effect site concentration, but at the same time, the blood pressure has gone down, cerebral perfusion pressure has gone down, and so you may have to use a vasopressor to support the circulation in that case. So you may have to use, some people draw up a vasopressor and use it when they are using TCI TIVA. There are new systems called the CLAD pump, that is closed loop anesthesia delivery system, where they have propofol, remifentanil or fentanyl, and they also have a vasopressor. And there the machine adjusts the dose of all these drugs. So remember one thing, whatever drug you use, whatever is your regime, whichever is your formula, make sure that you maintain the basic principles of anesthesia. And here, this is an aneurysm clipping, just to show you. So normally for my aneurysms, I put in a radial arterial line with the patient awake. And because it's very important to have good control over the transmural pressure at the time of the intubation, because that's the time where you can have some catastrophic rupture of the aneurysm. So here you can see heart rate is 60 and the pressures are well maintained. Okay, and and you can see the trend also. I've just shown one graphical trend, how the patient, the hemodynamics was controlled. This is a case of an awake craniotomy. Now, in an awake craniotomy, I prefer to have my patient fully awake. But with the advent of remifentanil, I give a low dose of remifentanil. See, the dose is hardly anything, 1 nanogram per ml. My patient has got a block and he's communicating with us. Okay. Now, this is a very interesting case. It's awake lesioning. It's it is a functional neurosurgery. So we had this patient for the first time. We wanted to do the patient awake with and lesioning, with the patient cooperating with us. Scalp block has been given. Remifentanil is going. She's awake with the frame. She's cooperating with us. She's fully awake. And this lady is elderly. She's about 74, and she had some comorbidities. So she's a case of dystonia, undergoing a paladotomy. This is the endonasal procedure. So many of you all who have done craniotomies, you know the hemodynamics are quite stable. Now, one of the most challenging procedures in neuroanesthesia is because of fluctuating levels of the pain is the endonasal procedure, endonasal decompression of a pituitary tumor. So, because you want the patient to be deep and then suddenly the surgery is over and you want the patient to be awake, and plus you're sort of sharing the airway, because when the patient wakes up, usually the nose is shut with the dressing, and the patient has to breathe through the mouth. So normally we used to use for controlled, I will not say hypotension, for controlled normal tension, we used to use esmolol and propofol, and some people used to use nitroprusside. But now with the advent of remifentanil, uh, you got a much better control. And you can see the pressures well maintained. And also to tell you that you can adjust the doses as you're going. As you're keeping a watch on the surgery, as I told you, it's not that you set a dose and the patient is on autopilot mode. So depending upon what's going on there, you can also adjust, increase or decrease the dose. Not that there's a fixed dose going into the patient. This is a patient also a paladotomy, a wake-up test and lesioning. Now here you can see this patient, I have intubated him. Of course, I've explained the procedure. So I've intubated him and yet he's awake. This is a case which I did more. No, this is another bilateral deep brain stimulation. See, this man, see, many of these diseases, the patient have suffered this for life. They are ready to do anything for you because they are like, this person is dystonic and it has crippled his life. He's got a normal brain, normal thinking, but because of these abnormal movements, his whole life has been crippled. So he is awake here, just a small dose of thing. We have applied the frame and we are about to take him down to the MRI. Now here, this is interesting. As Dr. Kalpana said, use of depth of anesthesia is also very important when you're doing these cases. So this is a case of, once again, deep brain stimulation for dystonia. Patient is intubated, no sevoflurane, depth of anesthesia is 31. See the hemodynamics. All the 4 twitches are present. And it's important. And now see here, the beauty of this monitor is you're getting the EEG value. It's very interesting that we focus so much on the ECG, but when we are dealing with the brain and awareness and anesthetic depth, EEG has always been something very complex. So here you're getting a processed EEG where you're getting you can make out the the EEG value here. You can see the spectral frequency and the median frequency here, the signal quality. All the 5 bands are there, and the EMG is 28 because this patient is not paralyzed. As I showed you, all the 4 twitches are present. So here, this is very interesting. So once as they are entering with the microelectrode, you can hear the crackling sound as the microelectrode is going to the globus pallidus internal nucleus. So those spikes that you see is the cells that are dying as the electrode is going in. This is called microstimulation, and this is macrostimulation. You can see here our neurologist is just checking the patient. Now here this patient too is intubated. Zero muscle relaxation, is intubated, is on remifentanil. And very interesting, actually, is not caught on here, but here the surgeon is telling me this is the miracle of your anesthesia to maintain that anesthetic depth, and still the patient is awake and intubated. And still he's cooperating for the micro and the macro stimulation. Very important when you're giving anesthesia. After the NICE guidelines, even the American Association of Great Britain, Anesthetic Association of Great Britain, has emphasized the use of depth of anesthesia monitors. We cannot keep on focusing on hemodynamics and saying that, okay, we know that the hemodynamics, the patient is awake or asleep. So here, what we have done is, see here, it's 35. A small bolus of propofol was given just to demonstrate here. And here you can see the BIS has gone down to 11. So in this thing, you can see a beautiful landscape. So here, the darker colors, the red and orangish colors are showing you a deeper plane of anesthesia. And as the plane lightens, as you can see here, the lighter sky, the sky that you can see here, it shows the lightening plane of anesthesia. So here, the patient is about to be extubated. You can see it's 96. So it objectifies the depth of anesthesia. So when you're doing anesthesia, especially with the neurosurgeon and the neurologist, they want to know that there is nothing going on and the patient is awake. So I show them the numbers. Otherwise, they'll keep on asking you, "Kitta diya, ye diya, wo diya." They may ask, but of course, my surgeons are very good. They don't ask me. But because I can show them the number. Now the depth is 35. All the 4 twitches are present. No muscle relaxation is on. Now I have reduced it to whatever. So important to objectify. Objectification gives you the evidence to prove, and then you don't have to answer anybody. So coming to the end, so it's recovery is rapid, faster verbal response to verbal stimuli, faster discharge after daycare surgery. You can see my patient already in the recovery room giving me a thumbs up. And a take-home message for you all is dedicated IV line. Keep your vasopressor ready in OT. Avoid boluses. Start during pre-oxygenation. As I said, in an infusion. Maintain at this is remifentanil specifically, and a slight reduction in heart rate and blood pressure is expected. Watch out for severe bradycardia. So now most of our patients are well beta blocked. So if the heart rate is 40, you don't have to jump the gun and inject glycopyrrolate or thing, because you have to see the blood pressure. If the blood pressure is maintained, there is no need to treat it. After stopping the infusion, flush the IV line is very important, because somebody may take and inject some antibiotic in the recovery room, and a bolus of the drug may go in. And ensure bridging analgesia with an non-opioid. So I give paracetamol, and I even give NSAIDs to prevent that hyperalgesia that may occur after you stop it. So there are issues, but you can always overcome them. Thank you.
Excellent presentation, sir. We will take the question later. Very nice of you to show your cases and real to show that how this TIVA and TCI can be applied absolutely for the safety of the patients and for the betterment of anesthetists and surgeons. I will welcome Dr. Foram Gandhi. She is a consultant at Jupiter Hospital. Her main interest is regional anesthesia, equipment services, and TIVA. She will introduce our next speaker for our next pediatric talk.
Good evening,
Dr.
everyone.
Foram.
Yeah, hi. Good evening, everyone. I would like to introduce Dr. Rashmi Shingade. She is a consultant pediatric anesthetist and a director of Children Orthopedic Center, Nagpur. She is also a governing council member, and her areas of interest are pediatric regional anesthesia. Today, she is going to talk on TIVA in pediatric private practice. Over to you, madam.
Yeah, hello everyone. Am I audible?
Yes, ma'am.
Yeah, I hope my slides are also visible.
Yes, they are visible, madam.
Thank you. Good evening, everyone, and thank you so much, SAMS, Office Bearers, Dr. Avinash sir and Sheetal madam, and ISA Thane, President Dr. Payana, Dr. Yateen and team for making me part of this interesting webinar that is on TISA and TIVA. So I will be talking on one second. TIVA in private pediatric practice. So the joint guidelines from the Association of Anesthetists and the for IV anesthesia in 2019 recommends that all anesthesiologists should be trained and competent in the delivery of TIVA. The triad of anesthesia, that is amblysia, analgesia, and muscle relaxation, is complete with intravenous drugs. Though the practice of TIVA in adults is decades old, but its use in pediatric is becoming popular very recently. TIVA is, as I already told by Kalpana ma'am, is a technique of delivering and maintaining general anesthesia using only intravenous agents, no inhalation agent, including nitrous oxide. So the understanding of all the favorable pharmacokinetics and dynamics of propofol, then availability of short-acting opioids like remifentanil, and invention of modern anesthesia gadgets like and are gaining more popularity, and also in pediatric anesthesiologists in just last decade. So though inhalational anesthesia is still widely used in children, but its popularity is for sure decreasing. And for obvious reasons, like the holding of a mask very tightly and the smell of sudden high concentration of inhalation agents is extremely uncomfortable for children. Again, the incidence of post-operative nausea, vomiting, and emergence delirium, especially after sevoflurane anesthesia, the incidence is very high in kids. Also in other cases, like where we have to share the airway and the anesthesia in endoscopy units or CT MRI, this TIVA is indicated. And of course, the suspected risk of malignant hyperthermia or muscular dystrophy, inhalation anesthesia is totally contraindicated. So all the disadvantages or contraindications of inhalations becomes the indication for TIVA Yes, that already said. And of course, during transfers, like from like OTs to the imaging techniques, or whenever you need to monitor like neuro cases where intraoperative SSP monitoring is required, TIVA is highly recommended. Coming to the pediatric consultation during TIVA. As we all know, the compartment volumes in children is almost twice that those as compared to the adults, and they have a larger central compartment and volume of distributions. So to achieve a given plasma concentration, the kids require larger boluses and initial high infusion rates. The adult values are usually achieved around the age of 15 to 16 years. So in children less than that, so during prolonged infusion, we have to be very careful because there is always a risk of accumulation. And after the infusion it stopped, it typically takes longer for a time for a child to wake up. These are the various drugs which we use for TIVA. The benzodiazepines, ketamine, yes, for the years it is a proven drug. Propofol, opioids, and dexmedetomidine very recently. And of course, for multimodal analgesia, IV paracetamol. Yes, propofol is the prime drug. The propofol trials have been started in 1977. So it's almost 40 years of clinical research that nowadays we are talking about. When we talk about propofol, we are not talking about like milligram per kg dose. We are talking about the plasma concentration and effect concentration. Yeah, of course, the remifentanil, and in private practice, yes, it is subject to availability. So coming to the methods. Actually, we have been using TIVA since our residency days. So like all the short procedures we used to manage with intermittent boluses. So from those intermittent boluses to the continuous IV infusions with the microdrips, then to the syringe infusion pumps, and now the target infusion, controlled infusion, we have come a long way. So I think we all remember managing all the close reductions, the INDs, but that time it was like thiopenton, Fortwin, and diazepam, yes, and just a hand on pulse and your eyes on respiration. That was the monitoring. But now we are doing with better understanding of all the kinetics and dynamics. We are doing it with propofol and fentanyl and with advanced monitoring. So these are the benefits. Of course, there is a high incidence of nausea, vomiting, and emergence daily in pediatric practice. With use of TIVA, definitely there is, as compared to the inhalational, the incidence is very low. And every school-going children will have an URTI. I mean, 8 or 9 out of 10 would have an recent history of URTI. So with very less incidence of laryngospasm and bronchospasm, this TIVA is ideal for children with recent URTI. Of course, there is an environmental benefit of less OT pollution. And yes, recovery is also very smooth, and parental satisfaction is there because child is quite quiet. And to start with, it's just a small prick, and within seconds, the child is asleep. So there are a few limitations as well. So limitations like with the recent like TCI pumps and all. So actually with cost effectiveness, they are not very free. They are not available in private practice, maybe in corporate setups and big hospitals, they are there. But then there is also lack of training and familiarity with the equipment. So these kinds of webinars and all these pre-conferences, workshops are very much warranted to make you acquainted with all the latest equipments and the methods. With propofol, of course, there is pen on injection. And again, once the IV drug is in, it is very difficult to reverse it immediately. You have to wait till the effect weans off. With prolonged surgeries and patients with low cardiac output or any critical illness, and especially in children where there is larger volume of distribution, there is always a risk of cumulative effect, and that might lead to prolonged recovery. And two major concerns, or rather the discouragement for use of TIVA in pediatrics is the risk of accidental awareness, and the other one is propofol infusion syndrome. So the pain of injection can very well be tackled. You have to just reassure the child. The preoperative counseling of the child and as well as the parents is also important. So preferably secure a larger vein, and of course, you will be using opioids. Of course, in private practice, we don't have remifentanil, but just fentanyl, pre-treatment with fentanyl or even helps a lot. Lignocaine, 0.5 milligram, the preservative-free lignocaine, that is 0.5 milligram per kg. I won't advocate it mixing with the propofol, but then just before we start with the infusion, it helps a lot to relieve the pain on injection. So next, still awareness. This is the main concern, and especially in pediatric practice. So it can be defined as intraoperative consciousness and the postoperative recall of intraoperative events. So the fifth national audit project that has reported very high incidence with TIVA when compared with the inhalational. And in pediatric population, the incidence was almost 1 in 60,000. But the major drawback of this was that it was relied on, the NAP was relied mainly on patient. They were who were reporting it spontaneously. And in kids, it is very difficult for the child to, tell you about the intraoperative awareness, and that too spontaneously. We even don't have a proper, assessment scale to in pediatrics, especially as we have in adults, but to the scales to assess the intraoperative awareness. So actual incidence may be higher. So the TCI-based TIVA and depth of anesthesia monitoring is recommended to reduce this incidence. So various factors contributing to this would be, just clamping of IV cannula or disconnection of infusion, like backflowing of the drug into the IV line if you are using the single cannula for both the IV fluid as well as the infusion. So all this leads to failure to deliver the drug. There could be drug errors also, like we are using the wrong dose, wrong drug, or wrong concentration. You need to check it again and again. And without using the TCI, there are high chances of underdosing. So even that can lead to awareness. And unnecessary use of muscle relaxants. Actually, we have a habit of giving relaxant at fixed intervals, like trachyrium or vacurinium, like 20 minutes, 30 minutes. So we have to correlate it clinically, and also the type of surgery which is going on. Like the surgical stimulus is different for different surgeries. So it has to be the judicious use as and when required. So just imagine a paralyzed patient who is awake. So that's a nightmare. So this is one more concern about the TIVA in pediatrics is propofol-related infusion syndrome. So the incidence is of course very low, but it is potentially fatal. And whatever cases have been reported, they are from PICUs where the propofol was used for post-operative sedation in ICUs, and the infusion, like it was more than 48 hours, and the dose was more than 6 milligram per kg per hour. And also the child who was already critically ill, who was acidotic and all, the incidence was even higher. Actually, the lipid in the propofol, which is the main culprit that interferes with the mitochondrial energy, ATP production, and leading very quickly to the rhabdomyolysis, metabolic acidosis, and multi-organ failure. So fortunately, it is very rare in our routine anesthesia practice with that much of short duration of exposure. So not a major thing to worry about. But then again, cautious use is indicated in patients who have a lipid metabolism, defects in lipid metabolism, or they are already critical, or having metabolic acidosis or anything already existing. So there's awareness and press. These are the main concerns which discourage its use. But then the awareness can be very well taken care of, and the incidence of press is very, very low. So how to get started with the TIVA? So IV access, yes, that's the main challenge in pediatrics. So you need to have a very good and trained support staff who knows how to handle the kids, right? So older children, like they may cooperate, but the younger ones, they find it very distressing. So parental counseling also helps in decreasing the anxiety level. Then in neonates, or when the child is obese, there is always a chance of poor vein visibility. In that case, a vein finder use or the putting an IV cannula in presence of parents helps. Distraction techniques, yes, I won't advocate that, but then smartphones and all, yes, they are good enough. I mean, child really get distracted and just you can take an IV. The last one, that is the inhalation induction. I won't advise it because I always prefer putting an IV line before any induction, whether it is, even if it is inhalational, but in very difficult cases, an inhalation induction can be performed, and then it is changed to TIVA once the IV access is secured. The preparation. So it is recommended to have a dedicated IV line for infusion and a separate line for IV fluids. And it should be visible throughout the procedure, and the infusion set should have a lever lock, so to prevent the accidental disconnections. And as I said, drug and fluid line should also join as close to the patient as possible. Syringes should be properly labeled with the drug name and the concentration. And to decrease the risk of contamination, the ampule, the neck of the ampule or the vial, they should be disinfected before. If you're using a syringe pump or TCI pump, the pump should be charged before or mains power during the use throughout the intraoperative period. And they all should have the alarms for high pressure and, blocked infusion or near empty syringes. And the most important point, even sir has pointed out, that all vascular devices should be flushed at the end of the procedure, maybe twice the amount of the dead volume of your infusion set, because if the patient goes in PICU and the sister there just flushes out, it can result in severe bradycardia or an apneic child. So the propofol infusion, we have manual mode and the TCI mode. Kalpana Madam has described it in very detail and beautifully, so I won't go into detail of this. Coming to the manual infusion, yes, for private practitioner, this is the mode most of them are using. So in this, it is given as a fixed infusion rate. So there is always a chance of under or over dosage. And then if you are not using the loading dose and starting with the fixed infusion rate directly, the plasma concentration rises very slowly and then it reaches a steady level after some time. So the concentration may be inadequate and then it may be excessive after some time. So if you don't have the depth of anesthesia monitor and also you have to correlate it with clinically and titrate the doses accordingly. So drug concentration has to be appropriate. Like should be just sufficient to produce the loss of consciousness and prevent the movement in response to the noxious stimuli. So excessive concentration or overdosing may result in hemodynamic instability like hypertension and of course accumulation and leading to delayed recovery. So the manual infusion regimens, they cannot be applied as rigidly without taking into consideration some factors like level of preoperative anxiety. We all know a 10 kg child, two different children with the same weight, they may have a different level of anxiety. All our doses are milligram per kg body weight, but the anxiety levels are different. So the same dose may not be adequate for both the kids. So there is a different level of depth of anesthesia we need for specific surgical stimulus, like if it's a laparotomy and or just a surface surgery. So then co-administration of other drugs, like we are using benzodiazepines, diazepines, the opioids, ketamines, the use of neuromuscular blocking drugs, or use of regional block for analgesia, or the presence of organ maturity, like in very small kids, organ maturity and dysfunction also, they are very important. In many studies have done, and they have confronted the use of remifentanil and a regional block for a good analgesia. They reduce the dose of propofol induction by as much as 50%. So we have to keep in mind all the other things also. So the Bristol regimen, which is for adults, has been already told by Kalpana Madam. So here the bolus is 1 milligram per kg and then the step down infusion. In pediatric, there are two regimens. First is the Macfarlane and Cullig's regimen, and the other one is Steer regimen. The Macfarlane is based on Kataria pharmacokinetic model, and it is for children 3 to 11 years, and that targets the plasma concentration of 3 micrograms per ml. The bolus is 2.5 milligram per kg as compared to the 1 milligram per kg in adults, and we know the reason for that. And then again, the step down infusion according to the time. And then if it is more than 2 hours surgery, it is as low as 9 milligram per kg. And if you're using it with remifentanil or other like regional anesthesia, it goes down even further. The Steer regimen, it is for kids less than 3 years. So if there is no bolus dose, and we directly start with the infusion rates. And again, the target plasma concentration is 3 microgram per ml. So in obese child, we have to take into consideration few things like the dose is proportional to the lean body mass. So it is very important that we calculate it. So it is actually the total body weight minus the fat mass. There are various scales to do this, and there are various formulas also to calculate the fat dose. And we'll always have to use the lean body mass for the drug dose calculations. Use of adjuncts. As Madam has also told, propofol alone will not provide good surgical analgesia because it's an amnesic drug. So we have to combine it with a very good analgesia. If available, remifentanil is the best choice. But if not, then use of other opioids like fentanyl or regional block also helps. So that they not only improve the surgical condition, but also limit the dose of propofol. This is about the remifentanil. It has got a very unique synergistic effect with propofol, and it's a very valuable adjunct. And if you don't have, sir has already told, it has to be given with the infusion. But if you don't have depth of anesthesia monitors, so like reduction in respiratory rate can be used as a marker for titration. So it is like aiming for a respiratory rate of less than 15 or a reduction in respiratory rate by 50%. So the only disadvantage is that it, though it reduces the propofol requirements by 50%, but it does not provide postoperative analgesia. So before we stop the infusion, we have to take care of the analgesia part, either with the regional or IV paracetamol or something. Dexmedetomidine, I have just started using it very recently, and not as an infusion, but as a bolus, and it's actually promising. And it adds further analgesic, sedative, and anxiolytic properties. Yeah, the recovery is typically, as I've already told, they have a large central compartment and volume of distribution. So it typically take a longer time to awake after a infusion is stopped. So for that, we have to take into consideration this context-sensitive half-life. It is the time taken for a drug's plasma concentration to decrease by 50% after a continuous infusion of a specific duration has been stopped. So this context-sensitive half-life is longer in children as compared to the adults. And for propofol, it is 10.4 minutes after 1 hour of infusion, and almost 20 minutes as compared to 9.5 minutes after 2 to 4 hours as infusion. So the infusion rates should be tapered towards the end of prolonged cases to avoid accumulation and prolonged recovery time. If the time permits, just a short case scenario. This is a 6-year-old 20 kg male child, a case of congenital dislocation of hip, which was posted for open reduction, VDRO, and acetabuloplasty. Estimated surgical time almost 3 to 4 hours. So to the first place, a good IV access, it's the most important thing. Then pre-medication with fentanyl, midazolam, and then oxygen supplementation throughout, and then induction with propofol 2 to 2.5 milligram per kg. After that, giving a good regional block, and then starting the propofol infusion in a manual mode. I usually mix 100 milligrams propofol in 50 ml of normal saline. That gives me a drug concentration of 2 milligram per ml. Initially, the rate is kept as is 5 milligram per kg per hour, and then can step down to even 3 milligram per kg or even 2 milligram per kg, where you have to relate it with the clinical parameters, right? So infusion is typically stopped at the skin closure, and the pain relief part is taken care of by even IV paracetamol, and post-op analgesia is provided with IV paracetamol and regional blocks. To conclude, understanding of favorable pharmacokinetics and dynamics of propofol and availability of short-acting opioids like remifentanil, an invention of modern anesthesia gadgets like TCI pumps and depth of anesthesia monitors, they have made our modern TIVA practice very safe, comfortable. But the word of caution, it should not affect your clinical acumen. This is very important because because it is just a pump, right? And clinical judgment is of paramount importance, I feel. And then lack of equipment, cost effectiveness, lack of proper training and familiarity with the equipment are some of the challenges in pediatric private practice. Thank you very much.
Thank you, ma'am, for a very nice presentation. Hello. Yeah. So now we have the discussion. Now we move on. Yeah, Poram. Hello. Hello.
Yeah, madam.
Yeah. So now you tell about the discussion part, the next topic.
Yeah, so actually I was waiting for the audience questions, but there are no questions in the chat box as of now for the speakers yet.
So I will ask one question for the speaker, whoever, Dr. Kalpana, Dr. Joseph. Sir, when we are starting a TCI pump, at what point we come to know that the CE, that effect target, the effect site has reached at that point of a time when we have started a TCI pump? So what are the parameters to know that we have reached at that point?
So it is displayed on the pump.
Okay.
Yeah.
So basically anything clinically like we have.
You set what you want to achieve, and then once you've achieved it, even that will be displayed. Understood. So then accordingly you
So
can
clinically,
decrease.
So anything clinically, we come to know that we have reached that half the target point when jaw relaxation for some muscle relaxation and all. So that during the recovery we stop the pump and we come to know that that effect, desired effect of C or the half is at 50% or 40% or something like that.
So there's no fixed formula for that. So now sometimes what happens is I don't like to stop the suppose it's remifentanil infusion. I don't like to stop it till the pins are out. So I keep it on a very small dose. So that way you avoid that hyperalgesia. So you should not switch it off completely. In the end, I want my patient to be awake, responsive, but I also want the patient to be pain free. So one thing you can do is when I come down to that 1 nanogram per ml, and I start paracetamol also towards the end. Give paracetamol towards the end. I even give if the creatinine is normal, I give diclofenac. See, it is not only about big opiates being used. You have to use multimodal analgesia. And in neuroanesthesia, I would also advocate the use of a scalp nerve block. The scalp nerve block, see, is very important to combine general anesthesia with regional techniques. As this doctor has said, okay, so once you give a good regional block, it could be a peripheral nerve block, your requirements will come down. But unfortunately, your TCI pump will not know that you're given the block. So again, I'm going back to this. The TCI pump is going according to this model and that model, but he doesn't know that he or she doesn't know that you have given this block. So so you have to see overall. Suppose when the patient is awake, you can make out easily. But if the patient is under anesthesia, hemodynamics may give you one clue. So, you have to monitor everything, whether it is the BIS, whether it is the hemodynamics, if the patient is and the patient state. So, see, it's very important. People
Okay,
always
sir.
talk about one point I would like to make because you asked me this very interesting question. So, people always talk about money. वो बहुत महंगा है, वो pump बहुत महंगा है, वो रेमिफेंटेनिल भी महंगा है. So, my point is, don't look at cost, you look for value. For me, using remifentanil and waking the patient up is not about I want to be fast. I don't want to make the patient fast. It is the fact that it will help me decide whether this patient does not require CT scan again. If the patient is drowsy, or if the patient is not responsive, or he's not mentioning his name, that's what we ask. So many things. हाथ पैर उठाओ, ये सब करो, जीभ निकालो, and then आपका पूरा नाम बोलो, and then we ask some specific questions depending on which side of the brain you're operating. So if they cannot do that, then there will be a doubt in the surgeon's mind. So अभी कुछ हो गया क्या? कि is there some hematoma collection? Should we shift to CT? So here you're getting ultimate neurological recovery, and they are very sure. So the value is also important. You look at the bigger picture. Don't look at the cost of that. And if you use it wisely, if you use those drugs wisely, you can have a good response using minimal use of the drug.
If I were to add, if I have the permission to, Dr. Havish, what we generally do is when we are taking the patient under and if we have used an effect site targeting, you continuously keep talking to the patient. As I said, you start off with zero point 0.5 to 1 microgram per ml and then go ahead slowly, slowly. At the time when that, of course, some amount of opioid is going on into the patient, as I told you, according to the kinetic of the opioid that you are using. And you can use the other multimodal. You can start off by giving a paracetamol. Magnesium also works very well. You can start the infusion first, paracetamol and a magnesium can be given first. Then start with your ME or fentanyl and then put in with your propofol. You keep talking to your patient. And at the effect site target, which is displayed on the monitor, which will tell you that you're kind of achieving that target. If you have set your target, say at 2, and you are now, your effect site is yet at 1.5, but you are talking to the patient and you find that your patient has lost consciousness at 1.5. He's allowing you to ventilate, means airway manipulation is, he's allowing you. So it is at that level that your patient is going to wake up again. At the
Correct,
same
correct.
time, at the end of the procedure, there is something called as a decrement time, which is there in the TCI pump, right? So it tells you that what is the time taken for that effect site to come down. Supposing a surgeon has finished the surgery and you feel now you're going to switch off the 20 minutes before the closure of the patient, you would have judged it with your patient, and if you're working regularly with a team, as Dr. Joseph mentioned, he's also aware that what his surgeons are, doing it. We work with a team, so we know it. So at that time, you kind of, get your the decrement time put at that, and it gives you a timing that in 20 minutes, the the effect size target is going to come down to zero point 0.8, 0.9, whatever you have fed in, correct? Whatever the time that you went under. So that is the time when your patient is going to come out. So you know that the patient is going to come out. Of course, this is always going to be assisted by your hemodynamic parameter. And also this will start increasing because now you're getting your patient out of the hypnotic effect, correct? But the analgesia has to be maintained vis-a-vis fentanyl or remifentanil, whatever it is. So decrement time or decrement concentration is very important. It is also called as a wake-up concentration in some of the TCI pumps, and that tells you that in how much time your patient is going to wake up. Basically, it's going to tell you in how much time your effect size target is going to come down to your desired level at which your patient went under in the first place. Got it? So this is the way you can always make out.
Yeah, thank you, madam. Thank you, sir.
At Dr. Kalpana, madam, there's a question in the audience that with remifentanil Minto model, there is a lot of hypotension seen in geriatric patients, and that's why it needs to be stopped. And then what can be done to have a better hemodynamic profile intraoperatively? Like how to, use
So as I
remifentanil?
said, remifentanil has to be titrated. The remifentanil target site concentration is around 5 to 7 nanograms per ml. If you your effect site target. So if you're going to straight away start off with 5, yes, you're going to have muscle rigidity. You're going to have bradycardia. At the same time, you're going to have this hypotension, which is going to be associated with bradycardia. Since I generally do all my cases are coronary cases, and I do use remifentanil. If I find my patients very well beta blocked or on codron, and they are the thing, I do give them glycopyrrolate if they come with a rate of 50, 54. And if I've decided to use Remi, I do give them a glycopyrrolate, which has got a little less tachycardia effect than what atropine would have. And then I start off. Always titrate yourself way up. And once you titrate it up from 0.1 to 0.2 to 0.3, 0.4, 0.5, I'm sure you will not be getting that much of hypotension. The other thing that you have is see that your patients are well filled up, number one. And number two, always have a vasopressor standby if you're using a total, propofol, remifentanil anesthesia. It's always safer to have your vasopressor standby. So I don't think we should have, because I deal with ejection fractions of 20, 25%. And titration has really helped me very well without any untoward side effects.
Also, if I may add, if there is any scope for giving a regional block or any other mode of analgesia, if that is also used along, then the requirement of your remifentanil also would go down. So
I think
that is
that would
also
be more prudent to be used in the late recovery
towards the end
phase.
of the case.
Yes,
Okay.
rather than in the beginning of the case, because then what is a great idea of using such a lovely drug, which is going to be one of the soft drugs that we have now. So aim is to get in faster, to put the patient under analgesic effect faster and bring it out faster. So maybe we should reserve these blocks, local infiltrations, and all that at the end of the procedure.
Okay.
Uh, can I add here? So I just want to share my experience. So when I started using Propofol TCI, so that time I started using Marsh effect, Marsh model. And as Dr. Kalpana, you rightly said, Marsh is harsh. And I experienced the same thing, that it was causing a lot of hypotension. So I was not happy and I was not comfortable. Then I started increasing the dose gradually next time when I used it. Then I was using that only, Marsh model only, for quite some time. But now I've started using Snyder and I'm extremely happy. I use Snyder for all the patients, whether it is, say, young patient, middle-aged patient, elderly patient, or any kind of patient. I use Snyder. Maybe for a younger patient, I would have to keep the concentration little higher. But I'm extremely happy with Snyder plasma effect site. So it doesn't give that, very big bolus. So it prevents hypotension, and I feel it's very good. So, and if you're inducing some case with Remi and Propofol, and you want to avoid giving relaxant. Many a times we do DL scopy and all those cases without relaxant, just on Propo and Remi. So you need a lot of patience here. So if you feel generally we give fentanyl, propofol, and the patient is induced. So here you have to have some patience and give little time and step up the dose, and then the patient will go under. So if you want to induce a case in a hurry, then maybe that's not the right technique.
I think once we start
Yeah, yeah.
using
So
Evolve
the
as
Elevate, no, I would like to add that the Elevate model is more versatile and it is an upgraded version. So it is like combining all the good effects of many other of the algorithms. But you must have a pump that has it. So maybe
Yeah.
when you're choosing your pump, you choose a pump that has got the most number of models. Don't choose a pump with fewer models. So then you can choose one against the other. And I would also like to say, see, the principles of TIVA are yours. So even if you have a simple syringe pump, you may use it well. And don't think that you require the TCI pump if you don't have the TCI. So you can use a simple syringe pump. You're getting an app, the TIVA, the TCI app on the phone, which is useful when you're starting. You can download it from the Google Play Store, TCI TIVA app, and it'll help you first initially if you don't have a TCI pump. Of course, the ultimate aim is you must have a TCI pump. And but I'm saying that even a manual infusion is good because in the manual infusion, once again, you're using your native intelligence and you're reading the situation and you're not totally relying on the TCI pump. So I'm again going back. I'm not an old-fashioned person. I'm telling you. So if you know the surgical steps and you're adjusting the pump, you see you have to change the mindset of turning the vaporizer to adjusting the pump. The same thing it is. You have to think a little differently. We are so used to turning that vaporizer. So same thing here. You have to learn to change the setting on that pump. Once you crack that code, I think you will do very well. And if you use, you should be able to titrate your anesthesia to that level. I will put in a word for the regional anesthesia again. Somebody had mentioned the thing. I think if you use the regional block, which is very popular now, definitely your doses will come down. See, India is a diverse country. Bombay is a diverse city. So what happened is from building to building, there's variation in costs and availability, and we must also be cost conscious. One side I said, okay, so you must be cost conscious how you're using it. It is very difficult to convince managements to buy those pumps because they say, अब तक तुमने अच्छे तरह से चला रहा था तो अभी क्यों वो 3 लाख का पंप 2 लाख का पंप क्यों चाहिए? You have to justify the requirement of that pump. So buy the pump, we can, but also be cost conscious. Indians are very cost conscious. You buy a car, they say mileage kitna dete. Yes or no? Even if you buy a fancy car, they want to know that mileage kitna dega. So that is an important thing. So keep the cost also in mind.
Yeah.
Yeah, I
So
agree with that. Sorry, if I may, keeping the cost and the dosage in mind, when you're in private practice, you have to use and consider other things like giving the block for one thing. But if you're doing procedures like a cystoscopy, hysteroscopy, and all, it would be worthwhile to keep everything absolutely ready. Keep your camera focused, the white balance, the irrigation fluid, the suctioning, counsel the patient, maybe give, a good dose of fentanyl and midazolam, which is what we use. We don't have remifentanil available to us here. So you give that, put the screen, and then you just actually induce the patient when they're about to start the procedure, explaining and counseling, telling them that, you cooperate with us and we'll ensure you're pain free, and this will help you wake up early and perhaps get discharged the same day. So I think all in all, it does make a difference. And some kind of dressing, debridement, wherein you can give a glass cut injury. If they can give a small block along with TIVA, it helps reducing the dosage.
yeah.
Can I say something?
Yes, yes, yes,
Hello.
yes, yes.
Yeah, I'm Dr. Tushar Choksi. I have heard this whole webinar. It was an excellent webinar, but I want to highlight about the cost and everything. See, in India, there are more than 12 companies are producing the TCI pump, including the foreign pumps and Indian made pumps, right? Now it is a third generation LEL model. Now we are building a fourth generation model with the artificial intelligence. But these pumps are available from free to high cost. Free pumps are available with the some of the company giving the drug use, like remifentanil is given by some company. They also provide with the free pump. But now when we brought this pump 5 years back, it was 2.5 lakhs rupees. Now it came down to 1 lakh rupees. So now the cost is not a major thing, because if you buy any vaporizer, then also it is 70 to 75,000 rupees. So my message to this webinar, all these attendees is that buy your pump. If you want to free, then contact us, all the IOTA members. We can guide you. And if you have a practical webinar point, then we can come to your hospital and teach you how to do the practically TCI TIVA. Like Kalpana, we are there. We are 10, 15 people all over India. We are the faculties. We are going to all the do the workshop all over India. We are doing at the national conference, state conference. So it is nice to see you all everyone. Thank you.
Thank you, sir, for joining. I didn't realize you were there in the audience. Yeah. So just a quick question to Dr. Joseph. So what is your experience with REMI in awake craniotomy? For all the awake cranies, you use it?
So the cornerstone of awake craniotomy is the scalp block.
Yeah.
So there are many techniques, and the technique of that conscious sedation has evolved with time, depending upon the availability. So initially, we started off with neurolept analgesia, but those were longer acting drugs with side effects. Then gradually came propofol, but propofol has got its own side effects because of it causes hypotension and loss of airway. So here we have want the airway to be also under control. So then onwards, we moved on to dexmedetomidine for a very short period of time. It is a very good drug and it still can be used. But dexmedetomidine has got a long plasma half-life. So sometimes when you want to waken the patient up at a critical moment, he may not be there. He will not be able to cooperate when you want him to. So fentanyl boluses have been used by some, and even we did use them. But then too, my technique was use of non-opioids like paracetamol, scalp block, and diclofenac. But when remifentanil came, it changed the thing because you can titrate it. It got a very fine control, and I give a very small dose, which I can stop whenever I want, and within 3 minutes, the effect has gone.
Okay. So
So
for all
sometimes the surgery has gone off well, the lesion has been excised, and then sometimes the closure takes time, and these procedures, suppose they're going on, they may get a little restless, and they can have some having a awake surgery can be distressing also. So that time you can just start a small dose.
Okay, so for all awake cranies we are using.
Yeah.
Yeah. And a little bit about pediatric neuromonitoring cases. Dr. Kalpana and Dr. Joseph, anyone can.
Pediatric?
Neuromonitoring cases. So intraoperative neuromonitoring cases.
Intraoperative neuromonitoring. Okay, intraoperative neuromonitoring. We use TCI TIVA. Is a combination of propofol and once again remifentanil. Now the problem of remifentanil availability is very poor because your hospital should get the license. But if you don't have, but we have it. So I'm saying so remifentanil and propofol. Okay, and I monitor. I told you whatever I monitor, the BIS and the TOF. If I'm doing a spine case and I want to do, I'm doing MEP monitoring in a pediatric patient, then I may use ketamine. Ketamine is also a good drug because ketamine increases the MEP values, the amplitude. It gives good analgesia, and a ketamine is another IV drug which is much malign. It has got many good effects. People treat it like an enemy, but it can be a friend if you use it well. So important to know the advantages and disadvantages of all these drugs and use it to your benefit. So low dose ketamine is also a good option for IV TIVA.
Yeah. So for all
There's a
the yeah. So for
Sorry, there's a question about the role of dexmedetomidine in this TIVA.
So I
In
mentioned
TIVA.
yes. No. So as I mentioned, it is a very good drug because it causes hemodynamic stability. It also it's a good drug to use, but it has a little long half life, so you should time it very well. If you are giving it for a patient who's in the ICU, who's being ventilated or who's on the ventilator, is a different matter. But if you want the patient to waken up, then that little long plasma half life is what I don't like. But it gives analgesia too because of it is not an anesthetic agent, it is an adjunct. You must know that. So it is not an anesthetic agent, doesn't give anesthesia. It is an analgesic adjunct. It may help you
Parna,
reduce your dose of the anesthetic agents.
So we have used,
Parna, I
I have
want to
used
highlight.
dexmedetomidine in cardiac surgeries. Sometimes, some of these cases will have really increase in the heart rate, especially when we are doing off-pump surgeries. And now, earlier, our go-to drug was a beta blocker, but now we move on to Dexmed. And I do not have three TCI pumps. If I would have had it, then I would have started with a Hannibal Collin model. But I do use a simple manual infusion technique. And so I've had fentanyl, I've had propofol and Dexam infusion as well going on in some of my cases, and I've got excellent hemodynamic stability with dexmedetomidine. Standard of a bolusing dose of zero point 0.8 to zero point 0.1 and zero point 0.3 to zero point 0.5 as your maintenance infusion.
I want to highlight in this forum. Now, remifentanil is available to each and every anesthesiologist from all over India. The procedure is this: you have to find out the stockist near to you, either in Thana or Bombay or whatever way it is there. And you have to write a triplet prescription to your patient. Patient will directly go to the stockist. The one prescription will be taken by the patient, one will be taken by the stockist, and one will you keep after taking the stamp and everything. Then they will come with the either 1 milligram or 2 milligram bulk. Then they can you can use. And for the TCI pump, if it is not available, at least start with the infusion. So plus my basic inspiration is you start the remifentanil. It is now not available. It is available to all the states now.
Yes, so we must make that new beginning. And to all the three speakers, if I can, in the end, say that supposing if I'm in private practice and I don't have TCI pump and I want to practice TIVA, so what is the take home? Like, how should I do it?
I think
Well, you
start
can
off with
start using
a
with a
syringe
simple
pump.
manual infusion, so
Yeah.
normal infusion pump. You can give Dexam through it, you can give fentanyl through it, you can give remifentanil through it, you can give propofol through it. You can use it. But if it's a pediatric patient, you can use your Stewards or the McFarland regimen for the same. And use multimodal analgesia, blocks, as they say, local infiltration, and you'll have a fantastic TIVA.
Okay. Dr.
There's
Joseph.
another thing which I just thought I should mention, that awareness is really important. So, post my surgery, the next day when I go and visit them, I do give them a Bryce protocol. It's a Bryce questionnaire which is available easily on the net. And I give all my patients that Bryce protocol, and they fill up their protocol, the questionnaire. So we know that the patients have had no awareness. So we don't have medical legal importance yet coming in our our country, but sooner or later that would be. So I do add a Bryce protocol, a Bryce questionnaire to all my PSE charts so that they can answer that questions after 12 hours or after 24 hours, as it may be.
Interesting. Dr. Joseph, I'm in private practice and I don't have TCI pump. What is your advice?
So no, see, listen, one must adapt to the local institution. So local institution, local practice. So uh, you have once you know the basics now and you read up and you have got availability of the drugs, I think you can start off with a manual infusion syringe pump. Okay. And I also say depth of anesthesia monitoring, I think also is one thing. And monitoring is very important. So I think start off with a syringe pump, but try to monitor a little better than what we are doing right now. I advocate even I use that nerve stimulator for every patient. The top monitor. It is now you talk about reversal agents, Sugamadex has come and all that, but I don't know why we do not insist that we should have a nerve monitor on,
Yes.
and the BIS monitor and the depth of anesthesia.
Rashmi, madam, your advice.
Private practice only. I've never done an institutional practice. So, yeah, the whatever said is like, if not with the infusion, like to start with, the syringe pump is the you can use it. I mean, I'm using a syringe pump for propofol, and the other like opioids, and I prefer the multimodal. Like for pain relief, I use this thing, regional blocks and IV paracetamol, and for amnesia thing, I'm using the propofol infusion, and it's good. I mean, it's difficult actually in corporates and big hospitals. Fine, we can convince the management and on they might go for TCI and all, but then in nursing home practice, it's very difficult to get an TCI pump. I don't think it is near future it will be, but then. Even though you don't have that, but you should be familiar with how the techniques, the methods, and how they are how it is used. Because once if you get the chance to do it, you should be ready for that. And I'm doing it since so many years, and my patients are really, I mean, they are very happy. The parents are satisfied, so I'm continuing with that. And it's a nursing home practice for me, so I don't see using a TCI pump in near future. But then, yeah, for corporate hospitals, it's possible. You can convince them.
Yeah.
No, I want to just add here that, when I went for the World TIVA conference in Chandigarh, there I saw a company called Clarity. Clarity. So they are sending their own made in India pumps designed in PGI Chandigarh. The cost they're selling is just 70,000 rupees.
Right.
70,000, 70, 80,000. So now just think about it. What I think that make in India should actually turn into a TCI pump. Maybe we make more local Indian pumps, like how we have got so many Indian ventilators, Indian syringe pumps. So similarly, some Indian company should, Tushar Chokshi, since you said, I think the TCI pump should be made in India. So then the cost will come down.
Sir, it is available from two companies from India.
Which one?
All, already it is available. You are just Clarity company is already, it is the
Yeah.
parent company of Dr. G.D. Puri.
Yes,
He has
yes.
introduced that pump.
Yeah.
Yeah. And one is this Mindre pump that is already produced now in India.
Oh.
So it is available at 90,000 rupees.
Ah.
The same pump, it is available in Germany, UK, everywhere. So now they give the free pump to use with the Thames people with the
Yeah, yeah.
remifentanil. So that's what my message is. You start using remifentanil. See, because one, આપણે એક કહે ને बहुत एक बहाना बता देते हैं कि remifentanil is not available. Then TCI, okay, TCI pump is not available for you people, but at least remifentanil now there is no question of any. You have to take the license and everything. You can directly prescribe three different. I'm doing. I don't have any license for having any Schedule 2 license or something like that. But I write triplet prescription to all my patients, and I'm using day and night to this remifentanil propofol. So it is made easy, and now these two other companies also coming with the remifentanil, and we are also getting within 2 years Cipro this remimizolam also from Neon. So they are in the pipeline. They are going on the second phase study now. So that is the news.
So that Mindray pump has got all the models. Huh? Please note.
Yes,
Yeah,
it
they
has
Yeah.
got
got Elevel.
Yeah.
In fact, the earlier pump had
Yeah.
Elevel 2, which was not allowing you to choose whether the opioid is used or not. Elevel 2.0 model, which is now being incorporated in Mindray, Mindray pumps, is going to give you the choice of an opioid being put in. The same thing
yes.
happened with the BD pumps also. First, I did not have it. So when I went to buy our pumps, I stopped the order and I said, no, I will be using the one with the Elevel model since I'm buying it once, one shot. I may as well buy the one with the latest thing. So if you're aware of the things, then of course you can always, bargain with the company and see that you get all your models put in. Arcomed also has all the models, again, a very user-friendly pump. Mindray is a very user-friendly pump. And this Clarity we haven't used, but I have just seen it. BD Alaris is giving us a good feedback with a good pump. I've been using the Nexus model since a long time. So all these pumps have got Elevel model, but basically you look for Elevel 2.0 model.
But according to me, all over the India, what are the pumps are available? I have used almost all pumps. So Arcomed is I am very user friendly and most reliable. And all think I think Kalpana, me and everybody is using Arcomed, and Arcomed has introduced in India since last 2 years, and they have sold more than 500 pumps alone in last year.
Okay.
I think there's one more question for Dr. Joseph. What is lesioning and what was the BIS value when the patient was responding to the commands in the midst of the procedure?
What was
The BIS value.
lesioning? Oh, okay. For the lesioning case.
Lesioning.
For the lesioning case, I had already explained to the patient that for you to cooperate well and to get the best result for this patient for your surgery, you'll be awake. You'll be awake. So, but you'll be pain free. I always give realistic expectations. So I told him what to expect. I didn't say that you'll be asleep and you will feel nothing. So awake, realistic expectations. So for that short period of time, when he was fully awake, he was pain free, and the BIS value was about 80. So that's see, of course, it's not anesthetic depth, it's 80. But I also noticed that when you switch off our anesthetic agents, and you may be even ready for extubation, sometimes the BIS value is around 80 to 80, 89. It may not be 100 immediately. So the value to reach 100 takes some time.
Yeah.
So in that patient, it was around 80 when he was cooperating.
Yeah.
One odd question I want to ask. If as in India we have money constraints, so if somebody has only one infusion, this pump, TCI pump, and one was to go for the infusion, then which one he should go for? Only in between the two, remifentanil or propofol?
I think it should be
TIVA case.
propofol, and then remifentanil. You can always use it as a manual infusion.
Any of our participants want to add anything if they're doing anything different in their private practice?
Sir, one more thing. When the people are not having an air, probably they're having only nitrous and oxygen. Then what about the role of TCI and TIVA in those cases in terms of not using an inhalation agent? Because nitrous also falls under the category of having a, in terms of definition of TIVA, basically we want to.
So no, I didn't get a question. It means I use only air and oxygen. So when you use TIVA, I use only air and oxygen. Nitrous oxide, at least in neuro anesthesia, increases the cerebral blood flow and increases the
ICP.
okay. So it increases the ICP after some time. Now the nitrous oxide that was used by Priestley is still going around in this universe. So my point when I'm talking about TIVA, so why do you want to use nitrous oxide? We have got, in those days there were no potent drugs. Now we have got so many potent drugs, and so now nitrous oxide. Suppose you're talking about a cardiac, then it decreases the cardiac function. There are so many other side effects. So if if you don't have access to air and you are using nitrous oxide because of a constraint, I will not say anything, but I will recommend I don't use it at least. I've stopped using it. So, and it is an environmental pollutant also, and it stays in the atmosphere for hundreds of years. Tushar Chokshi may say something more because of that. People are talking about desflurane. Even desflurane disappears
See,
faster.
in TIVA definition, if you use any gases, then it is not called a TIVA TCI.
Yeah.
That is my basic answer. You have to use except the oxygen and air. That's all. You have to use only IV agent. No nitrous, no sevoflurane, no other any inhalation. That is only then call it is TCI. If you want to have this mixed anesthesia, then you can use inhalation with TCI, TIVA, whatever it may be. But it is a jugglery. You either use this model or use this model.
Okay. So, thank you. Thank you very much, all the speakers. It was an excellent lecture and a webinar. Now, Dr. Bhavesh, please. Hello.
Hello. Yeah. So thanks all the speakers. Now I will hand over to Dr. Yatin. He's a consultant freelancing practicing at Kaushalya Medical Hospital, Criticare Asia, and he will be giving a vote of thanks for the things. He's very much into this regional anesthesia for high risk cases and all. So he's an excellent anesthesiologist, and hand over to Yatin.
Thank you, Dr. Bhavesh. Good evening, all. On behalf of Thane Anesthesia Society, it is my honor and privilege to uh, deliver the vote of thanks for today's insightful webinar on TCI TIVA. My heartfelt gratitude to our esteemed speakers who enlightened us with their knowledge and experience. Dr. Kalpana Shah for her explaining and simplifying and explaining fundamentals of TCI and TIVA. Dr. Joseph Monterio for his excellent insights on neuroanesthesia and patients with awake craniotomies and his experience in patients with different comorbidities. Dr. Rashmi for sharing practical aspects of TIVA in pediatric population in private practice. And special thanks to our panelists, Dr. Bhavesh Nanda, Dr. Shamini Iyer, and Dr. Foram Gandhi for making this discussion very enlightening. And I also thank our SAM's office bearers, respected Dr. Avinash Bhosle sir, our president, Dr. Shital Dalal, our honorary secretary of SAM's, for joining and supporting us. I would like to express thanks to our technical team led by Mr. Ganesh for making sure or ensuring seamless execution of this webinar. Uh, I would like to thank our president, Dr. Parna, and all the office bearers and the scientific organizing committee for making run everything smoother and as good as TIVA propofol infusion. I also thank our attendees who were there till the end. Total 92 attendees and
100, Yatin, we have
100. Oh yeah, 100. And we know it's
more than
TIVA.
100 go on YouTube, so we would not receive login
We
there.
know it's TIVA, and I'm sure your attention was not in total intravenous autopilot. So together we grow and share our knowledge and uplift the excellence in academic excellence in anesthesiology. And thank you all for attending this webinar. And with this, we conclude today's webinar.
Yeah.
Thank you. Have a
Dr.
great day.
Anita Nete,
No,
who
no,
is the
I also thank
I,
Anita
I,
madam.
I would like to talk
Madam.
before.
Okay.
yes, sir, please.
Yeah. Briefly. First of all, congratulations to Dr. Parna and the team and Dr. Yatin, everybody. Number one. And number two, you must have read today's paper. There's a big shortage of blood in Thana. In fact, Dr. Joseph, last week we had to postpone one surgery, rather we told for B positive not available for a transnasal pituitary. And similarly, O positive was not able. And ISA Thana collected more than 51 bottles on 9th of this
19th,
month and congratulations
October.
19th October. So it is a great job for ISA Thana. It's a hats off to our team. Thank you very much. Sorry for the interruption, but I think I must share. And today, Thane Vaivod is a big news, big shortage of blood in Thana. And they have requested the housing societies and the various NGOs to arrange blood camps because lots of donors are out of station. So, yeah, thanks. Congratulations to Parna, Dr.
Yeah,
Parna
that's
and
a
team.
great job.
Yeah, thanks. Okay, thanks.
Thank you,
Thank you.
Dr.
Thank you.
Kalpana, Dr. and Dr. Rashmi for excellent presentations, really. Thank you very much.
Thank you so much for having us. Thank you.
Thank you.
Thank you.
Thank you. Thank you so much.
Senior faculty is Dr. Dhaigude madam, then Dr. Krishna Joshi sir, many people were there. Then Dr. Tushar Choksi. It was a pleasant surprise, sir, that you joined. Thank you very much. Yeah. Okay.
This is Reddy speaking from US. I have been watching this webinar since a long time, and I am very thankful to Dr. Sunil, who has included me in this group, in Thane group. And when I visit to India, I would definitely come to Thane and meet all of you. And you're doing an excellent job. Actually, every day I'm following the Thane anesthesia group, and today I'm much. I mean, the way the Dr. Joseph has presented about TCA and awake surgery for neuroanesthesia. And I worked in neuro for a long time, nearly 4.5 years. I worked in Kurnool Medical College. And at that time, we were not having this awake surgery, all those things. And if I come there, I want to visit even Hinduja Hospital. And I would like to thank Dr. Joseph for presenting this one. And all the presentations are excellent today. It's more practical. It's more practical, not theoretical. And I'm very much happy the way you people are interacting. And Mr. Gandhi, he has presented about 1 month back about TCI, and he is moving with his own pumps. He has got his own pumps and he's practicing since nearly 20 years, he said, doing this job. And he is a pioneer in this, actually. So
Thank you very much.
Thank you, Dr. Joseph.
Sir, you're welcome to Hinduja whenever you want.
Yeah, thank you very much. If I come to Bombay, definitely I shall come and visit Hinduja Hospital.
Yes.
I'm not practicing for the last 10 years. I'm just retired and staying in US. I'm 80 years old. And still I'm interested academically. That's why I attend all these webinars.
Thank you, sir.
Thank you.
Kind of you, sir. Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you. Good evening. Thank you.
Thank you.
Thank you.
Right.
Thank you, everyone. Shall we conclude the meeting now?
Yeah.
Thank you.
Okay, thank you. Thank you, Doctor. Thank you.
Thank you.
Thank you, Doctor. Congratulations. I say long list.
Family wise.
Yeah, Dr.
Thank
Kiran
you.
Chandrana is also there. Thank you.
Okay. Thank you, Dr. Rashmi, Dr. Kalpana, Dr. Monty, Joseph. Okay, bye.
Thank you so much.
Nete madam was also there.
Yes, sir.
Anita madam. Oh, yeah. Thank you, Dr.
I
Thank
wrote
Dr.
it.
Yadita,
I
Dr.
wrote it.
Anita madam, Dr.
Yeah.
Thank you, Nete madam.
Avinash sir, Dr. Avinash sir has gone. Okay. Okay, chalo. Thanks. Thank you. Bye.
Bye-bye.
Thank you.
Thank you.
Thank you,
Bye-bye.
Nate.
Good night.
Thank you.
Thank
Good
you,
night.
Nalgi madam. Okay. We can stay for some time. गणेश रेकॉर्डिंग बंद करा ना रेकॉर्डिंग बंद झालं गणेश
इसको क्या लीव करना ना यहाँ से?
या जस्ट लीव
Yes.
या गणेश को बोलते हैं देन वी कैन अच्छा सर भी गए
सर रहेंगे शायद.
ओके देन वी विल आल्सो लॉग आउट देन वी विल टॉक अबाउट द ट्रैक
Later, na? Okay, now.
हाँ नहीं लेटर
Later.
हाँ
It was
दांत के साथ
wonderful
बात
webinar.
कर
Super
थैंक यू
awesome.
अच्छा था ना
Topics were awesome, and I did not expect. But when I saw a total 100 people, I mean, I thought that till 92 I was saying that. So
हाँ
it was a superb response. I mean, everybody was so much interested in learning this thing, and our speakers, all the three speakers were awesome.
yes Dr. Shailesh Mulgaonkar had also joined so
Wow.
so
Cool.
बहुत अच्छा हो गया
बहुत अच्छा.
थैंक यू बाय गुड नाइट
All right, good.